Hello, and welcome to today's health webinar. This episode is brought to you by our friends at IMO Health. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Francesca Wutke.
Hi, everyone. Good morning, good afternoon, and welcome to the webinar. So we're here to address a structural issue in healthcare data that's still not getting enough attention. There's a persistent disconnect between how clinicians naturally describe care and how our systems require that care to be coded, standardized, and ultimately analyzed. This gap is not just a technical inconvenience, it directly impacts data quality and introduces friction into clinical workflows and increasingly undermines the reliability of the inputs that we're using to power analytics and AI. And as organizations accelerate investment in AI and in automation, this becomes a foundational problem. If the underlying data doesn't accurately reflect clinical intent, the outputs will not be trustworthy, no matter how advanced the models are. Today's discussion is focused on how we're going to close that gap, specifically how a clinical interface terminology layer can serve as that bridge between real-world clinical language and structured interoperable data. The goal is straightforward but critical: to translate intent into data that's usable, scalable, and AI-ready without adding additional burden to clinicians. So with that, let's get into it. I'm Francesca Wutke, and I'll be your moderator today. John, why don't you please kick us off with introductions?
John Larson, I would assume. We got two Johns on here, but I'll get started. Thanks, Francesca. Hi, everybody. My name is John Larson. I'm the Senior Vice President of Product here at IMO Health. My team and I think about how we bring IMO's ontologies and our knowledge graph to bear, predominantly in the health technology market. We work with organizations who provide software and analytics back into the provider space. That includes our EHR partners, but also revenue cycle companies, analytic companies, and so on. So welcome. I'm excited to be here and have the conversation.
Todd, why don't you go next?
Sure. My name's Todd Sharp. I'm with Amazon Web Services. I act as an executive technology advisor and field CTO. 30 years of high-tech software development experience, 20 years of that in health tech, including postings on the provider side and payer side of the equation. And I'm excited about this topic, primarily because if you're a technologist, you know with AI you need a semantic layer so that it can translate through your business goals and needs. But if you are looking at a clinical thing, then as a trained emergency medical clinician, I also recognize that precision is important. And we need to have solutions that help us translate between both of those sides of the equation so that we can put AI to its biggest, best use.
Thanks, Todd. Tim?
Hi, everyone. I'm Tim Riddle. I work for a company called Premier. We serve 2 out of every 3 providers in America and life sciences companies. Easiest way to say what I do is my 11-year-old daughter, I tell her daddy tells stories of healthcare data to keep people safe. And you can't keep people safe if your data isn't good for AI. So work a lot with 25 years in both ventilators, medication cabinets, and fusion pumps, as well as performance improvement. Nice to meet everyone.
Thanks, Tim. And Dr. Lee, last but not least.
I'm John Lee. I'm an emergency physician. I've been a CMIO at 2 different organizations. Do most of my work in the Epic space right now, and big believer in data governance and data quality.
Excellent. Well, I'm looking forward to this discussion with these experts, and I think we'll have a great chat. In terms of each of your individual projects on your own tables, what is the piece of data governance that's really keeping you up at night as you're launching AI into provider workflows?
Well, I can maybe start. So For the last 30 years, IMO has been providing content through our ontological models into EHRs to help physicians document. So if you're at Northwestern here in Chicago, where I'm at, or Johns Hopkins, when a physician documents a diagnosis, they're not free texting that. They're actually calling to IMO's content layer to find that clinical concept, make sure it's highly accurate, highly specific, and then we push that back into the electronic health record. So when we think about the governance needed, we think about essentially language creation and how much we have to be careful when we create a new clinical concept so that it's not only accurate, but it's unique. It can be mapped appropriately and that it's usable by the physician, our physician users that are about 97% of the physicians across the country use IMO every day today. So as I think about AI, that ontological governance and that model that needs to be in place to ensure that a model's not hallucinating and creating a totally new clinical concept out of fresh air. We've built that editorial policy over the last 30 years that ensures when we create a new variation of a procedure, a new variation of a diagnosis, that it's grounded in that governance, and then can be deployed across the healthcare ecosystem.
So I'll go ahead. I think the thing that really keeps me up at night with regard to this next step that we're going to take using AI, and I think we all acknowledge that AI is dependent on good data, and but the data that we've put into the system has been coarsened and semantics have been removed just because of the lean towards billing optimization. So just a simple example from IMO's content, as an ED physician, if I admit a patient, I will write the diagnosis as acute chest pain. But if I end up discharging the patient home, the IMO term will be chest pain of undetermined etiology. I think both of those actually point to the same ICD-10 code.
They do.
And I'm not sure if they point to the same SNOMED code, but semantically, I choose those two terms very intentionally because if the patient is being admitted to the hospital, to me, my concern is that the patient has a little bit higher moral risk. But if the patient's going home, I may put chest pain of undetermined etiology and then maybe a secondary diagnosis of gastroesophageal reflux. So there is something being lost in that, and with artificial intelligence, we need to try to keep that semantic layer in place if we're going to optimally use these data tools.
Yeah, Dr. Lee, I think that it's a wonderful example. I mean, the gap between what you mean as a clinician and what a system records is really where healthcare value can disappear. You know, it's where denied claims live, that gap, and where quality measures break. Population health cohorts can fall apart, and AI recommendations, if that semantic layer is not unified, can go wrong. So we see that in data regularly regarding treatment, and the system is set up to bill properly with ICD-10 codes, as two of the speakers have mentioned. So it's really that gap between clinician intent and system records where we can have challenges.
I mean, those ICD-10 codes and those SNOMED, I mean, those ontologies that exist out in the world, they were really built for different things, right? I mean, ICD-10 was built for a billing, grouping, classification function. SNOMED was built more for a research. I mean, we really want an ontology that really understands the physician language, right? And can capture that clinical intent. Still has to map to those. We still can't not bill, but having that extra layer of granularity there is really what we're trying to bring into the AI world now.
And I just think from my perspective, since there's already been some great examples of clinical workflow, I think about the analytics workflow. So, nurses and quality improvement folks are underwater, and something as simple as creating a patient list, right? So I want to type 1, type 2 diabetes, and I want to use that to help follow up. I want to use that to help improve care, maybe retrospectively even. Typing all those codes individually, making sure they all match, right? Making sure they all work in a cohort builder or something like that is extremely laborious if you're just typing them one after a time. So a lot of what we are using ontologies for, or what's keeping me up at night, is how do I improve some of the non-EMR clinician workflow so that they get to improvements faster and kind of get the insights to action. And some of that stuff is still buried and it's not necessarily in EMR. So how do we use those ontologies better? And how do we test them with questions from a governance perspective? Like, this question should have done this, and this is the result.
And I think, one of the things that we keep struggling with as we try to actually improve our healthcare system, and I think there's broad recognition that the CPT-driven fee-for-service has really kind of corrupted and hijacked our efforts to try to make a good healthcare system. And then the natural corollary to that is that we want to say, well, we're going to pay for quality. But this all then circles back to, well, how do you define quality? And what we've had to rely on are these coarse data metrics of what is, an ICD-10 code. And, even diabetes, we have this this nuance now where for decades, even centuries, we have had type 1 diabetes and type 2 diabetes. What we're now recognizing is that there's like a type 1.5 diabetes and maybe some other variation in between. And then you have other metabolic disorders and you have insulin resistance. How do you capture all of that and use that in such a way that we can actually then improve quality and actually prevent disease rather than being reactive to an ICD-10 code and try to get some sort of financial gain from that?
Absolutely. And we have a comment that came in from one of our audience participants, that's kind of corroborating what has already been said in terms of, it's not an AI misinterpretation issue as much as it's a representation and clinical intent problem. Because, if we think about how AI is working and the data sets that it's learned from, it's in many cases faithfully using data that's maybe incomplete, but it's where the clinical intent is not clearly inputted or on the edited from the outputs. That's where there can be a difference in how healthcare is deployed or how these patients are going to get reimbursed for their care. When we think about all of these very complex systems and the overburdened healthcare teams that we know are just absolutely doing their best in light of all of these changes, how do you ensure semantic interoperability where when AI is sitting across so many different data standards and data sets and workflows and in some cases systems?
I'm really interested in Dr. Lee's assessment because he counsels so many CMIOs on this, but I'll do a bit about kind of how we perceive it in the world on enterprise healthcare. So, I mean, there's documentation that needs to be captured. So we think very hard about how we ensure that we minimize the effort for the physician to capture that coded specificity. And that requires really thoughtful terminology development to ensure you have things like, this is a little nerdy, but bear with me, pre-coordinated terms that really allow a physician to say breast cancer metastasized to pelvis stage 4. To an oncologist, that makes sense. They understand what that means, but that requires 3 SNOMED codes and 2 ICD-10 codes. So can we streamline that initial capture and then provide in our payload all of that coded representation that'll power the analytics and the billing functions down behind the scenes. That's kind of our role we've been playing. As we move into the automation of that with AI, how do we help, for example, working with ambient partners, how do we help them identify those pre-coordinated terms and coalesce those in from the transcript itself and pull those nodes together so that we can identify diabetes with tingling in the feet means diabetes with peripheral neuropathy. Like there's some logic there, but you need real structured context and a really strong governance layer to pull those pre-coordinated terms together. But we have to make it easy. I think that's the real challenge. You can't expect a physician to remember 3 SNOMED codes to document that accurately. That's not what they were trained for. We want to give them that terminology layer that makes sense to them.
And John, maybe for the more data naive amongst us, can you or someone else on the panel drill down on what's meant when we say ontology versus taxonomy?
Yeah, I mean, and there's all little variations in this, but the ontology is really not only the words themselves, but the relationships to each other. So you can think about diabetes, what is more specific than diabetes? So there's a relationship, diabetes type 2 with insulin dependence. There's a relationship between those, and that essentially structures your ontological model. We then bring those specific ontologies for like a problem or diagnosis domain and then map them also to others like medications treating the diabetic condition or procedures that are ordered for. And that kind of represents a broader knowledge graph that can help an AI model reason over any data itself.
Great, thank you for that. And I'm sorry, Todd, you were about to say something.
No, I was just going to contribute that, we often think that our physicians, our clinicians, our revenue cycle specialists, everyone in the value chain internally is only as good to some extent as the training that they had. And when we move into the AI realm, it's kind of similar. AI is only as good as the language it learned from. And this should make us all feel a sense of urgency. I mean, our director level health system and health tech leaders are either already deploying AI or being asked to justify AI investments. And so the insight I'd like to share on this is that terminology inconsistency is not a data hygiene problem so much as it is an integrity problem. If the training data reflects coding habits rather than clinical reality, to the other speaker's points, the model learned the wrong thing. And no amount of fine tuning fixes a corrupted foundation. So we should look at this in terms of an opportunity to reframe our terminologies into humanistic terms that we can all understand more easily, whether you're a technologist, a clinician or not, from a back office concern into a board level AI governance issue. I would hope that our audience leaves today asking their own teams, what did our models actually train on? And have we set ourselves up governance-wise for success?
And I guess I would just add, coming at it from a different point. So we have 1 out of every 2 claims in America, and we have over 200 rules that we apply to get that data clean to use a semantic or interoperability model, to look at an ontology. And so, even the bare metal of where the data is, it can be clean. Now, EMR, that's obviously very hard, but back to what John was talking about. But we're starting with rules that help clean the data to go in, back to the point Todd made, right? If the data is not very good, it's not going to be able to use an ontology model. It's going to give you broken references. It's going to give you a CPT that doesn't exist. So we're, at least when we try to give our organization's benchmarking data, we're making sure that the AI data is ready, it's clean, it's trusted, so it can use those ontologies. So we can ask the question simply of, give me a list of type 1 and type 2 diabetes patients.
So when I talk about semantics and some of these ontology issues, I often use a pretty kind of humorous anecdote where we actually used some of the SNOMED hierarchies to group certain diagnoses together. And so we had cardiovascular diagnoses, we had gastrointestinal diagnoses, and it helps the clinicians sort and chunk these sometimes really onerous and large problem lists. But when we first started using this, we had some feedback that said, hey, why are hemorrhoids being categorized as a cardiovascular problem? And that's because within the SNOMED hierarchy, hemorrhoids are a venous problem, venous are a cardiovascular problem, and it kind of goes up there. So we actually had to insert that semantic layer of in a Boolean expression, everything at the node of hemorrhoids we exclude from cardiovascular and put into gastrointestinal. So that's the sort of work that we have to do. It's a small example, a little bit humorous, but it's still very real. And I think that where we might have an opportunity is instead of putting square pegs into round holes, the square peg of what is a clinical meaning, what is the semantics of something, in forcing it to the round hole of a SNOMED code or an ICD-10 code, I think the current technology stack affords us a potential opportunity. I'm not sure exactly how this would work, but if you think about how we are currently using a lot of these newer AI tools, when I interact with these LLM tools, I'm not a data scientist, but I understand enough to know that, hey, I have to construct, say, a prompt or a markdown document in such a way that it can be semantically received, and I don't necessarily have to be a Python programmer. And I think in a similar way, there is maybe an opportunity that instead of using ICD or SNOMED or LOINC or whatever as kind of the round holes that we squish these square pegs into, maybe we can start interoperating and transmitting semantics using Markdown. I'm not sure how that would work, and certainly the billing and the regulatory and the insurance would be a problematic, at least in the beginning. But maybe the solution is actually our current modern AI technology stack.
And Dr. Lee, that's
just one question on that. Man, do you think,
please.
so I mean, you're kind of saying, hey, we had these other ontologies, ICD-10, SNOMED, they were purpose-built for something else. We're trying to apply them into this semantic layer to unlock this AI power, but are you saying that I mean, kind of ignore that, come up with a new way to describe or a new layer of that really reflects the clinical language in a markdown?
Well, I think flipping the switch is at this point is unrealistic.
Sure.
But I do think that we should try to work our way to that and actually start infusing some of the subtleties and nuances of semantics and language and the fuzziness of taking care of patients actually into some of the data and encoding that we have in conceptualizing what is a sick patient, what is not a sick patient.
Yep.
And I think, and if you think about how we've structured everything the way that we have, it's basically because we didn't have this sort of technology available when we created these billing and coding constructs in the 60s, 70s, and 80s. Now we do. Maybe we should start thinking about repackaging this up and using modern technology to actually paint a digital picture of what is quality.
Yep.
Yeah, we're doing that in a microcosm by sending a natural language prompt into an ontology and then looking backwards at what we have in the code set. So there's still a human in the loop. And luckily, in this example, we're not playing for keeps. It's not like, emergency medicine, but the user can at least ask a natural language question. It can get a result. They can adjust, right? rather than having to be forced into looking through 50 ICD-10 diagnosis codes, CPT codes, whatever. And I think I really like that analogy of, could we not flip it on its head? Maybe not right away, but thinking about how people think of things, either lay people or clinicians, ask them to prompt it and then get a result might be a better answer in some cases.
And there would have to be some sort of accountability layer and some sort of it can't be just a black box. And we should be able to say, well, you said that the patient had acute chest pain as opposed to chest pain of undetermined etiology. What did you mean by that, and why did you label it that way as opposed to this other label?
And
Agreed, like a human in the loop.
yeah, and I think as we think about how AI is reducing some of these asymmetric dynamics between payers, providers, we can see some of that tension and friction in terms of how we're defining things and how the patient outcomes are being impacted. You gave us, Dr. Lee, a really good example of how a patient might negatively experience or have an adverse outcome based on the way the billing requirements are influencing the diagnosis and diagnostic codes. There might be a scenario too where a woman presents with heart attack symptoms, but that they present very differently than a man does, and if those learning sets don't incorporate as many women as men, potentially those outcomes might be slightly different. Are there places where we can see AI reduces those asymmetric viewpoints between payers, providers, and the outcomes that patients are getting?
Well, I think theoretically, definitely. I'm not entirely confident that the payers would give up that power asymmetry. Typical when you mention, say, females who come in with cardiac symptoms or potentially cardiac symptoms, you could easily see that if they come in with very atypical symptoms and, just because of social biases, you, as an ED physician, you may end up labeling that ED visit as anxiety. And then so the insurance company would say, well, that was not an ED visit. We're going to deny that claim. And all of a sudden they have a $3,000 ER bill. But if we ended up having some other infrastructure rather than a specific ICD-10 code that gets attached that theoretically encapsulated the entirety of that ER visit, there could be almost like a graph database of these are the types of symptoms, and this is why the patient came into the emergency department, and she was short of breath, she had palpitations, and this was a reasonable reason to come into the emergency department. Yes, the patient may end up having anxiety as a final diagnosis, but that doesn't mean that coming into the emergency department was an unreasonable thing to do. And so, again, square peg of this constellation and the complexity of why people come into the emergency department or seek medical care, and trying to fit into the square, the round hole of a nice tidy ICD-10 code.
Yeah. I kind of, maybe I'm jaded because I worked in revenue cycle for so long, but I don't see the payers embracing that nuance in the near term. I am seeing health systems kind of embrace that understanding and taking down both within their claim editing and their billing rules, trying to get to a much more specific understanding of what is being denied using a different layer of terminology there. They do that for a couple reasons. One, it gives them some intelligence in some of the patterns that the payers are denying, but also allows them to alert in a much more clinician-friendly way through the encounter. So kind of moving some of those billing rules to the left. You can't show a physician an ICD-10 because there'll be way too many false positives, but could we show them a nuanced alert or claim edit based on something more specific to that patient's condition that they will understand? So I'm seeing the earlier health systems getting out in front of this, and trying to take back control of some of the asymmetry on the lack of understanding of who's getting denied and why.
And John, where we're seeing it is at scale is within the provider environment. Let's think about what Dr. Lee shared, right? Over several decades, we've taken what was individual clinicians, rural doctors, top academic medical centers, and we boiled the ocean down to an ICD-10 code, losing all of that fidelity of the extra dimensions that are truly focused on patient care. What one could argue with a value-based care approach, the payers may embrace this a little more because we can add those dimensions back in. How could you do that? With this type of semantic layer, because then you can query from any dimension and see the through lines. So that is promising. But in this world where it's no longer payers and providers talking to one another, to your point, it's revenue cycle specialists and providers. And if you look at the billions of dollars we have per year that's sitting in suspense accounts, and our providers that are averaging 3% margin and barely keeping their doors open in some cases, it's because the cost of readjudication and resubmission is too high. So by putting a semantic layer in place where an AI can make reasonable choices based upon how to package down those dimensions into an ICD-10 code and get the maximum value back in the health system, so the health system is healthy to then help the patients and the payer gets what it needs to help its members, is really no longer optional. You know, it's not optional infrastructure. It's a prerequisite for everything else right now. It's not a nice to have sitting on top of an AI strategy. It's something we should have had coming all along over the last several decades. But now with AI, I think we're exposing, to Dr. Lee's point, that there's been a bit of folly as we've tried to boil and distill all of the essential information out of it, because it's the foundation that determines whether the AI strategy works at all.
Yeah,
Ambient listening products, for example, they produce more unstructured text. 97%, 2024 survey, 97% of all data gathered by health systems goes unused. So ambient listening can produce more unstructured text, but without this type of understanding, the stores are going to have inconsistently coded records, and agents will reason away from noisy inputs rather than the appropriate structure that allows them to follow that entire through line. It's no different than a human challenge, but because of the speed and efficiencies, I argue it's far more critical we solve it now.
And all I would say is that part of this may be solved, very difficulty though, with looking at, like you mentioned, at the unstructured text. So you think about equality measures and how people are paid on outcomes. What we're attempting to do a lot is take where it matters, some of the NLP technology, and give it a little bit more robust to that ICD-10 code, so that our providers that use our tools can say, hey, yes, I know I coded this. I know this is being flagged as a quality alert and I'm getting dinged on reimbursement, but what else was in the chart, and what might I have done differently, back to revenue cycle or coding and documentation, differently next time, to encapsulate some of those more. It isn't as simple as it looks, right? But it encapsulates some of that more detail, to either code it differently next time, or at least understand that this isn't really an improvement opportunity. I'm getting dinged on this, but I could do differently next time.
Well, there's all sorts of, to the point about data that is not actually captured in any sort of discrete manner. The example that I've been using recently is that, it's widely understood, maybe not as solidly as we would like, but generally speaking, if you are, what can promote health is good sleep, eating right, exercise, exposure to sun, and having a good social network. There are no ICD-10 codes that are associated with that. There's no CPT codes that are associated with that. And so if you could, I mean, and then when you have that discussion with the patient, that stuff goes off into the ether. So if you could have a discussion with the patient and say, hey, how much exercise are you at? Oh, I walk 3 miles a day and I get 20,000 steps a day. Or I sit around and I sit at my desk, do my knowledge work, and then I watch Netflix all night long. Those are two dramatically different scenarios, and we should try to actually capture that in some sort of manner. And I think that barring any new ICE or SNOMED codes that are available, I think what we should start doing is actually start capturing that, maybe as untrained, unsupervised learning, start clustering some of these concepts and start figuring out, hey, the people who have this sort of cluster do well. The people who are in this other cluster don't do well. How to actually put that into some sort of payment framework, I don't have a good answer for that, but I think that's the direction we should start going. And then on top of that, as we're thinking about this, it's almost like the metaphorical blind man around the elephant. What we should have is a corpus of data, which is the elephant, and then what we should present is, the snake of the trunk, or the tree trunk that is their leg, and have that manifest to whomever needs that sort of information. I've often rankled at this concept of the problem list, which is an artifact of the 1960s and 1970s, where we had to do everything on paper. I think we shouldn't have to necessarily curate a problem list. The problem list should be a different dynamic list depending on who's consuming that sort of information. And it's not something that we have to actually curate or monitor or put effort into. It should just be kind of an exhaust of all the stuff that is going on with the patient.
Are you guys seeing out there that the LLMs can create some of those clinical concepts, like you just described, Dr. Lee, independently? And what's your guys' comfort level with that? Because I mean, OpenAI has put out papers around ontological development through the LLM itself. Um, as enterprise healthcare people, I'm just wondering how that makes you feel about the LLMs essentially creating net new clinical concepts, and how would you want to govern that?
That's a really difficult question, but I do think that, I have seen some examples where the terminology is created, but
Yeah.
there's no real good mechanism to insert that into the record, nor to the point that I just described, at least in my opinion, nor should there be a canonical place to put it for a particular encounter or for a hospitalization. Um, I, I think that sort of output should be a result of a query, say from a payer or from the patient or from a consultant who wants to get some sort of quick summarization of what's going on in the chart or what's going on with the patient. I think there's no infrastructure or reason to actually use that in any sort of in any sort of way right now. The reality is that we still have to put in these codes.
Yeah,
And I think, we're
Okay.
no, I was just going to say we're getting
Go
all
ahead.
of this information in, and it's still essentially being whittled down into claim codes. So we're losing a lot of the data that actually may benefit the patient and the payers should be interested in, because it would cause lower costs overall.
That's almost a regulatory challenge, though, because I don't want to flag wave the regulatory flag necessarily, but the way payers are at scale incentivized, and the way that they actually thrive to be able to provide plans to customers and members, doesn't always align with this enhanced, enriched information that we've been talking about. And, that's a fundamental miss that maybe over time we can solve more nationwide. But we see it in other countries too. It's not just something in the US. We see it where there's socialized medicine. We see it where there are, private versus public payer plans as well. So the frame isn't, I think that we're all struggling with right now. The frame isn't really add a terminology layer to your stack. It's that we already have a terminology problem, and it has the potential to silently degrade everything else above it. And so looking at, garbage in, garbage out, the old adage, but looking at the gap between what a clinician means for patient care versus what a system records for member reimbursement is where revenue, quality, and AI accuracy can all quietly bleed out.
Yep.
And that's where this semantic layer is so important. The terminology layer isn't really part of your AI strategy. It's a prerequisite for anything holistically working well, including AI. The one thing I did want to bring up is a governance layer. If you look at Amazon Bedrock, for example, to your point earlier, John, it allows an organization to set up security, compliance, and regulatory guardrails so that the AI models are actually operating within those parameters. So yes, while an LLM can and has proven to be able to do that research and that iteration and that evolution, we've seen it with everything from life sciences and pharmaceuticals to unique molecules that can be used and compounds that can be used to unlock disease therapies. We've seen it all the way down to that point of patient care where an AI assistant with the proper knowledge can actually maybe suggest in that woman patient coming into the ED presenting potentially as cardiac, but being triaged as something else. We can see it intervening. We see it in contact centers. We see it with clinicians where when we as human beings treat our AI with trust, when it has earned our trust and we trust it and we treat it as a collaborative team member versus a tool, we see an average of 33% greater ROI, return on investment or return on benefit in that use of AI. And there's a workforce study research paper that came out 2 years ago from Asana Workforce Labs that reinforced that with data. So it's us using this data and the semantic layer to create trustworthy AI. And then in turn, us having that psychological emotional switch where we flip it and we started treating it like a knowledgeable colleague, neither an untrained, ignorant one, nor necessarily the expert, but a knowledgeable colleague with whom we can consult.
So
Todd,
when you
go ahead.
Todd, when you talk about ROI, my experience within the healthcare system is that ROI is almost always captured as increased revenue and basically increased volume. But my personal opinion is all of these data tools, the real macro level potential is actually in a cost reduction and to use an insurance term, demand destruction. But there's a lot of people who would be very, very have serious problems with that because so much of our infrastructure, including a lot of the administrative people within the system, both on the payer and the provider side, their bread is buttered based on the current model and not based on actual.
There are those points, but I think also we see it in efficiencies that allow health systems to thrive more easily. For example, MRI, CT scan, pick any kind of expensive diagnostic suite. If it goes underutilized, two things happen, right? One, the investment isn't paying off for the community that's invested in it. And two, enough patients aren't being seen to actually get its benefits out into the community so that things can be treated earlier and cures be administered. So what we have seen is, for example, radiologists. If you're a radiologist and you have to look at 80 images a day, that's an okay day. But if you come in and you have to look at 140, that's a pretty bad day for you. And you're likely to miss something, just cognitive dissonance being what it is. Through the use of AI, we often see an increase in throughput, yes, but also an increase in catching edge cases as well as quality throughput. In one study, actually, you saw 54% greater utilization and throughput of scheduling efficiencies, and that returned value to the hospital for that investment. So when I say return on investment, I agree with what you're saying about demand destruction and such, but we can be talking about significant investments that can perform better for the wellness of the patients as well as the health of the system.
Is that creating a supply abundance, Todd? I mean, Andreessen Horowitz's article about that essentially is just supply generation will now allow for ease of access.
I think there's a valid argument around that without a doubt, right? And again, like everything else, it's good governance and guardrails that lend us to where we need to make these human in the loop decisions as to where those boundaries lie for the benefit of the communities we serve.
Just a question, Todd, because you were talking about Bedrock and some of the, for the group, what are some of the ways that you provide grounding to your AI models? Dr. Lee, I know you prompt all the time, you're working with all of them, but how do you ensure the tools that you're using are grounded in a clinical valid way, or to give you that trust of a colleague that you mentioned, Todd?
Yeah, that tends to be a combination of model provider being transparent about how they trained a model. With us in Bedrock, we're model agnostic, right? We have models from Anthropic, we have models from OpenAI, we have models from Mistral, we have models from hundreds of different availability, and using Bedrock Foundry, healthcare customers can actually create and train their own models and put them into use too. So it's really more about governance and guardrails that meets the organization's compliance needs, whether that's HIPAA or high trust in that security sense of the word, or if it's an ontology, or if it's examining that EHR data, perhaps that 97% that often goes unused. It really comes back to the training and the transparency. If you don't have an understanding of ethical AI and the training models that were used and the data that was run through, then it's very hard to develop the trust on the model without a lot of testing and analysis. And even then, you should be doing the testing and analysis too. We don't send trained doctors into the field after their residencies and let them practice for 50 years without continuing education, do we? We shouldn't do that with AI models either. It's not a tool that sits there and spins. It's a tool that acts and reasons. And this is a fundamental shift from workflows and automations of the past. It can act and reason probabilistically, but it's acting and reasoning on the inputs we give it. And so we should routinely recertify and re-examine, and I think verify, maybe even using a clinician's continuing education model. I wrote an article on that about a year ago, that using a continuing education model for AI to validate bias, hallucination, and other dimensions are being rightfully incorporated is feasible, and it's something we're familiar with in healthcare. So it's not a stretch for us to do that and apply it to AI agents, just as we would to human agents who operate within the system.
We had a question around that just came in from one of the participants. It says, it seems that models must be further trained on the semantics and meaning of each medical subspecialty initially and eventually on the much larger corpus of medicine. It's expensive and time consuming, but seems likely necessary to gain greater clinical integrity. I think that certainly speaks to the point you were making, Todd.
I would agree.
Yeah, I think there's case there. There are sources. I think as we've been talking about some of these ontological models that exist out there, there's purpose-built sources that you can leverage within your AI models to do things. Like if you are building a model on billing codes, I mean, you can leverage ICD-10 and CPT. So I think there are ways to to help your model reason, your frontier model reason with knowledge graphs or ontologies that are publicly available, but you need to make sure that they're purpose-built for what you're trying to accomplish. So if you're trying to apply ICD-10 modeling to clinical decision support, you're going to fail. Your false positive rate, your frustration of your physicians will be too high. So you just need to make sure you're gathering the right source of information to help your model reason.
And
And I
I
think
think we've taken that approach where we've really narrowed our scope, even on analytics models. So when it's asking a question, John, we're asking it certain questions, we're gonna have answers. We're gonna be able to validate it. And then the final thing is we're trying to narrow the scope of what we're using this for and training it more narrowly. That is more work, but I do think trying to throw a model at everything and ask it hundreds of questions is not always the best answer.
And I think that the whole governance issue is another kind of meta issue on top of this, in that the natural reflex of the healthcare industry is to, when they say governance, I have an image of 24 people in a boardroom looking at PowerPoint slides and ruminating over something. And given the volume of stuff that we and content that we're going to have to review, I personally think that we need to figure out ways to actually use the technology, use AI to actually govern AI. And there's no way that we're going to actually accomplish what we need to accomplish without actually using that to scale our ability to do that.
Remember, Dr. Lee, you gave that example when you were looking through, what was it? What was the regulatory modification you made at where you used AI to summarize all of the options for your team
Oh
to
yeah.
screen?
Oh, you mean the heparin?
Yep. So
And that was a relatively easy task, but we had to think about doing it that way to um to actually accomplish it. Once we actually decided to do it and we had that ideation, it was relatively easy. The technology was there. And I think we have to start doing that in more broadly to actually handle the load that we're going to be inundated with over the next few years and in the near future.
There's one other correlate to this I want to think about for a second, and that is actually the patients themselves, right? How do they trust the AI that is being presented to them at a digital front door or in some kind of a health dashboard that the system provides? And again, I think security is one thing. Does the organization in that governance model, does the organization that's offering the service do so in a private and secure manner? Or is it doing so in a way that is using publicly accessible models that could leak PHI, for example? I know as a patient that's of great concern. So I think it does go back to what is the security compliance and governance guardrails that any organization uses, not only in the training of the data, but in the accessing of the information to make sure that patient safety is reflected not only in clinical treatment, but also in the data and representations that are made.
Yeah,
there's
actually, I
a
think that's a fantastic point, because what is actually happening now? What people are doing is they're taking their entire medical records and dumping it into ChatGPT and trying to get some sort of insight. That is not a good practice for privacy, and also because of some of the data governance and semantic governance issues that we've described. Wouldn't it be better if instead of handing a patient a 50-page discharge instructions of these are the things you need to watch out for and these are the things that you need to do, instead say, here's a link or here's our app, chat with it to try to figure what is it that you need to do. I'm taking my medications in the morning. I remember that the physician told me that I had to change something around. What are the things that I need to take care of? And that, I think, is actually a very doable paradigm. It's just that we haven't actually created the tools and the infrastructure for that yet.
Well, that unlocks another layer of kind of semantic interoperability, right? I mean, converting clinician-friendly terminology to patient-friendly terminology is a massive intellectual understanding there. And so that would require another multiple nodes on that graph to link all this together.
So I think we have several semantic layers that we need to work on and continue to develop the billing and the clinical, as well as the patient and end user, so that everyone's speaking more or less the same language and getting to those great outcomes that we're looking for. This has been just such a great discussion. I don't want to cut it short because I feel like we can go on talking about this for hours and hours, but I do want to thank these expert panelists for giving us their perspective. Also the audience, there were great questions that were coming through that we were trying to manage during the course of the conversation. And thank you to IMO Health for sponsoring this webinar and for putting this great group together. So thank you all. Any last minute closing remarks from the panelists about how we can see these models gaining momentum over time?
I'll just comment. I mean, there's a lot of builders on this call, people that are trying to have a positive impact. And so keep going. I think my team's here to help you kind of provide that clinical context and that grounding to your AI models, to bring some of that clinical intent back in and try to abstract or get you out of that billing world. So, but this is an exciting time. We just got to strike the right balance so that we don't dumb down the data, frankly.
And I would
Go ahead, Dr. Lee.
I would say that we have to really avoid the temptation to create faster horses, because that's most of the innovation that I'm seeing right now. Let's maybe start thinking in terms of first principles and try to figure out what we are trying to accomplish, and then completely re-engineer the plumbing so that it actually accomplishes what we want to accomplish, rather than just making the stuff that we've been doing over the past 4 decades just faster.
And I would just add, agile approaches sometimes work well here because there's so much complexity. So increment something, see if you trust it. If not, pull it back, try it again, right? Rather than trying to boil the ocean and go big bang with this stuff. A little bit of improvement can go a long way.
Todd, closing words?
And I would share that in the world of large language models, it's no longer experimentation. They're being deployed, they're being used, they're being of benefit today in production environments. There's no reason, with all the elements we've touched on today, that a builder can't make a solution that provides benefit rapidly in a cloud-based environment at scale and with security in place. The challenge is working mostly through organizations and cultures that are not only wanting to hit the brake instead of the gas, but perhaps are focused on running the engine rather than improving how the engine runs. And I think that ties back into what Dr. Lee was sharing as well.
Well, thank you all for joining us today. This has been a health webinar, and look forward to seeing you on another one.
Thank you to IMO Health and to everyone that joined us today. Please visit our website, HLTH.com, to catch up on all health webinars and watch the recording of today's session. Join us in Amsterdam, June 15th to 18th for Health Europe,